Well, welcome to the NorCal Medical Advisory Committee Run Review, March 1st, 2016. Thank you all for joining. This will go up on the web. If any of you have interesting runs, challenging, good care, bad care, just would be good to discuss, please send them to me. Scan them, email them, smoke signal, fax, text. I'll take it any which way I can. So, case 1. Dispatch for a 64-year-old male with chest pain. Responded code 3 for chest pain. They found the patient sitting on his sofa attended by his spouse. Doesn't sound like he's looking too good. Pale, clammy, nauseated. He's alert, oriented, with a GCS of 15, probably better than me today. His wife gives the initial and the basic history, probably because he's just not feeling that spiffy. The chest pain began about 15 minutes ago, and he has been treated for some type of throat infection and cough. So, the last bullet makes me start thinking, is this cardiac? I'm not sure. Is this pleuritis, pleuritic pain, pneumonia? Although there's a certain percentage of all cardiac patients who will have chest wall pain who are having a big MI. Always be leery of that. So he's transferred to the gurney, placed on oxygen. Wife gives the wallet and the current meds in the bag o' meds. I'd rather have the bag o' meds than see nursing notes any day. It's one of my concerns. So the pain has been mid-sternal, which comes and goes. Pain became severe, was 10 out of 10, now it's 8 out of 10. Maybe he's been sick and now he's experienced cardiac pain. I don't know. Describes it increases with inspiration, doesn't radiate. Still, interesting they became sweaty, nauseated, and short of breath. That sounds more sudden onset. Denies any significant medical or cardiac problems. Vital signs assessed. Now, this is kind of interesting, and when you look at the EKG and the monitors, the medic says that the monitor shows AFib with what sounds like a rapid ventricular response, but when they did a 12-lead, the dreaded 12-lead interpretation said SVT. Kind of worried me because I'm thinking, yeah, you ignore the computer printout and you should analyze it yourself. We'll look at the strips in the 12-lead. And there's an inside joke between Mr. Lane and myself. So the patient's very irregular with a rate. Oh, forgot to put the... Yeah, okay, there's a space between the rate and the range. Between 120 and 170. Monitor reports the rhythm is SVT with the right bundle branch block. No SC segment changes. No JVD. I'm assuming they're talking about tracheal deviation. Some people just want to mention trauma even though there's no history of trauma. I like this. The chest is stable with equal rise and fall. Lungs are clear bilaterally. That's an interesting note. They do give 324 of aspirin, and they're transported code 2. Started an IV in the left AC. Call the hospital. The nurse wants the 12-lead. Now I really kind of don't like this. The hospital advises upgrade to code 3.
Have them not do that to me.
I think that's wrong.
They said, you're coming in with a STEMI, possible STEMI, you have to come code 3. That's their rules down, at least. I know Enloe does that, because that's what my students are saying. I had Mercy tell me I had to come code 3. Of course, I only turned the lights on, so I did it. But
We had it happen too in a snowstorm where you're not code 3 because it's not safe.
Yeah, interesting concept.
Yeah.
it's a STEMI, so it's got to come code 3.
Yeah, no. If the ambulance crashes and the patient's killed, I guess it really doesn't matter that they're code 3 or code 2. Yeah, it really bugs me. No more nausea, difficulty in breathing, skin signs have improved. They tried to text the 12 lead, didn't work. What a surprise. Now, I see this a lot, and I have to rely upon the providers here who are listening. Why do they put no further contact? I just kind of think that's a given. You give report.
The only thing I would write at that point would be available.
Okay.
But
Tylenol, Robitussin, levofloxacin. Okay. Awake and oriented, normal neuro, normal eyes, clammy, ashen. I like that word ashen. Less breath sounds are normal. Abdomen. Whoops. Bye, guys. Cervical, lumbar, thoracic, nothing. Here are all the wonderful blood pressures.
gee, it's surprising that every respiration's for
Are 16?
an hour or half an hour, all 16.
I thought that was interesting too.
Just changing.
The pulse flips all over the place. I'm thinking more AFib. And established IV. So here's the first rhythm.
If they are calling that SVT, somebody needs to go back to school.
That's kind of what I thought.
I don't care what the machine says.
It's
Well,
like a standard AFib, really.
here's what the 12 lead is.
And still, that's still AFib.
That's kind of...
It's close, but I'll bet you if you took a few minutes, it definitely shows up right here.
And lead V4?
Yeah.
Yeah.
4, 5, and 6.
Mm-hmm. Particularly 5. There's right,
Oops.
crap.
Well, 4, 5, and 6 are pretty much the same picture, so keep going back. One more.
There it is.
If you look at V5, you can really see that the RR interval changes. So, yeah, they didn't look at this 12 lead very closely. I still call this fib.
Now, why is that? Why is the computer calling it in the 12 lead? Why is it calling it SVT?
Because algorithms aren't always perfect, and the machine can get confused.
What's it? What's it? It's looking at something on that.
It's looking the R to R's.
So it's for the response. Okay.
But if you
but
take
it's-
a look, some of these actually look real. If you don't look too hard, that
Look
looks
pretty
like
regular.
a regular.
Yeah.
But it's not. If you take that one
You have to count
and
boxes.
that one
Yeah.
and count boxes or whatever else, you can see that it's not. It's close.
Really
It's close, but no cigar.
So that's what it's looking at then.
Yeah, it's just saying that it's close to a good R to R.
Right.
The R to R's fit within
Yeah.
a variable for sinus arrhythmia or something.
I wonder if it takes, if it averages for.
It may. I don't know enough. A friend of mine's into that stuff. I don't know which algorithm they're using. I've seen false positives before like this. I've seen, EKGs that say acute MI, ****, and yeah, no. So, again, it goes back to the basics.
And why did they write a bundle branch? You don't, just, this is not the very cleanest EKG on this, and I know.
It's probably got a minimal interventricular conduction delay on some of it. I wouldn't call this a bundle branch block either.
I mean, by quickly looking at it without getting out your calipers and all that stuff, the QRS does not look that wide.
No, it doesn't. So,
But, okay.
shame on the medic.
But treat the patient and
Right.
we'll see you at
And
the hospital.
here, and
See,
here,
that one is definitely a fit.
right. So I think the documentation was good. Caliber of the care was good. My only concern is that they didn't explain why the machine was wrong.
They just started a line and wasn't his pain like a
8 out of 10.
And it was a 10 out of 10?
They
they
gave
give
him
some-
aspirin, but that's it.
That was,
Yeah, they didn't give him any MS or anything else.
No pain management at all.
They didn't try nitro. I think they're thinking that this was more pleuritic.
But, excuse me, but pain is pain?
Pain is pain. They should have given some analgesia. So the teaching take-home point is don't always believe what the 12 lead tells you. That's why when I got trained way back when in the dark ages, I'd fold the interpretation over so I couldn't see it and be biased by it.
We just tear it off when we're teaching our students.
I do. Well, it used to be you'd say, hey, what do you see? Well, what do you see? I concur. Let's ask the hospital real quick. What do they see? I mean, it was one of these, you triangulate the information thinking, okay. But it never changed how you treated the patient.
Right.
Yeah.
So, I mean, close but no cigar. Okay. So, here's another interesting case. A 54-year-old with syncope, spondyle code 3 head injury, lying on the floor, small amount of blood behind her head, abrasions to the right side of her face. Here's one thing that doesn't make sense to me. Incontinent.
Yeah.
To what?
They didn't say. They didn't say
There's a
urine.
difference.
Yeah, that's a good point. If you
There's-
wet your pants, one thing. If you've soiled yourself, that's something totally different there. And talking on her cell phone, there's another little.
That's typical, but okay.
Well, I'm surprised you put that in there, though. I guess it's self-explanatory, huh? Taking pictures of us as we walked in or something.
Mm-hmm. So it was witnessed walking in collapse, hitting her head with a loss of consciousness from a period of time from 30 seconds to 1 minute. Onset of timing being 20 minutes prior to EMS. The incontinent thing, I've seen syncopal episodes and they're not usually incontinent.
Seizures.
So did she fall, whack her head, and have a post-traumatic seizure that they didn't notice or didn't know about?
Did she have a seizure and fall
Yeah, and cracker head.
and crack her head?
Right.
Chicken egg. Now
It's a moot point, but right.
although the witnesses, of course they don't necessarily have to clonic tonic, but was there anything? Did she make a sound? Did she complain of anything?
Nothing.
I mean, because not every seizure is a full body
Tonic-clonic.
tonic-clonic kicking chicken. Yeah, flopping and all that stuff.
So, pay attention. Patient was put in spinal precautions initially upon arrival. Patient was alert and oriented. The person, place, and time answered all appropriate questions. Denied having any shortness of breath, chest pain, etc. No neck or back pain. Great. The thing that caught me was spinal precautions were waived at this point. What do you think they mean?
What I'm assuming that they held manual head stabilization until they could get a good assessment and with a good assessment, they decided that they didn't need to hold manual stabilization. That's my assumption.
That's
It
what I'm
doesn't-
hoping.
It doesn't mean that they put them in the full body thing and then ripped them out, because that doesn't say that.
That's what I'm hoping.
Or fire have to have them with a seat collar and minimum.
So, she's had a syncopal episode before, felt sick to her stomach, and flushed. Last thing she remembered was walking and waking up on the floor. Pretty unremarkable review of systems. Interesting, she said she's seen a cardiologist for a low heart rate, discussed a pacemaker, and I don't know why he put her on an aspirin.
Heart rate at 36?
Yeah.
There's no doubt about the chicken and the egg now.
Yeah. 36 and no ectopy. You'd think something would go, hey, fire off here.
No headache, no dizziness.
Said she felt flushed. I don't know what do you think that was?
Not sure. Neurostatus, pretty good. So it's interesting that she's supine.
And they said the orthos didn't change.
Right, well, one, I wouldn't have done orthos on somebody who'd had a syncopal episode.
We know the problem.
But she look with a pulse rate of 34 and she's 165 over 83.
It doesn't make sense to me.
Hypertensive and bradycardia.
Right, so,
And she felt flush. I'm trying to.
Yeah,
I don't know.
Flush with a hypertension makes sense.
Yeah, but this bradycardic.
the blood pressure and the heart rate don't make sense.
Now,
And-
is she symptomatic bradycardia?
Well, they don't say where,
She's not.
what
she's
position.
she's 15.
But
Skins were normal.
But she passed out.
But I mean now, once
So,
right on C.
did she go from 36 to 18? And thereby going thud.
Oh,
The respiratory rates were all supposed to be 18.
Did she vomited?
She was nauseated.
No headache?
Well, she does now that she whacked her head.
I was thinking blood pressure 157 over 90, heart rate at 37, with vomiting and a headache.
Cushing's?
Yeah, I was thinking it was the beginning of a bleed. That's
Yeah.
what stands out in my mind looking at it.
Yeah, I was thinking that too. Yeah, that's classic Cushing's reflex. The only thing that doesn't make sense, and it can happen before you get respiratory and failure and apnea. So there's her heart rate. There's her strip, 3 lead.
It's definitely bradycardic.
Oh yeah.
Just a little slower, and we could be doing pumping and blowing.
No
Yeah.
kidding.
I'm sorry, 30, a heart rate like that, I don't care what it is, it's too slow. Nobody survives well on a heart rate of 37. I mean,
Mm-hmm.
even your,
but she's compensating. She's talking to him. She's
but
doing all
how,
this
where
stuff.
is she on that curve?
I don't
Well,
know.
You're right. She could be this close to, but it's like you would expect it.
I would have given her 0.5 and see if that made a little bit of difference.
Oh,
It wouldn't
bring her
have been too much.
And I would have put the pacing pads on her.
Oh yeah, I would have had, because if you're not careful, she's gonna, going from 37, all she needs to do is drop 10 points, and that's not uncommon in a lot of people.
Yeah,
Yeah.
I'm just
So-
amazed she's compensating.
I don't, to be honest with you, I don't believe the blood pressure. There's something just doesn't, and if you do believe the blood pressure, Mr. Witherall was right, then did she have a bleed?
But then you'd think there'd be, there'd be other things associated with that, either alter or arm drift or something associated with that. Now, you're right, the incontinence, now, it'll be interesting to see what the final thing is here.
I've got to check on her. I found this case over the weekend. And her 12 lead, I'm like, oh crap.
Can't tell whether there's ST elevation because there's not enough complexes.
Exactly.
Yeah, you can.
One complex does not make a rhythm.
Oh, you big weenie. So, I think the documentation could have been better. I think that the care was overall, I don't know, I would have given her atropine, put on the pacers as a precautionary measure.
What about them not doing C-spine even though she hit her head and had a stated loss of consciousness with a potential incontinence? And again, we don't know whether the incontinence was before or after or whatever else.
Yeah, I kind of am worried about waved off C-spine. So there's lots of things in here, and I do have the PCR, and I'll be reaching out to the medic and get more information. I'll hopefully be able to remember to bring it back to the group. So, case 3, a 7-year-old, altered level of consciousness, sitting on the couch, aphasia, garbled speech, no trauma. Now the interesting thing is onset of symptoms, 12-11 hours yesterday. So that's and the reason why when you get into it more is that's the last time known well.
And how did somebody get that accurate?
That's pretty good.
Yeah.
Yep, you're acting goofy, it's 12:11.
Well, that's when the daughter said they saw the dad around noon.
Oh.
12, I wouldn't have said 12:11. I'm like, yeah, okay. So this morning she called 911 because she couldn't get a hold of her dad. And family say the last time patient was seen normal was approximately 12 yesterday.
See, that's what I would have written, approximately 1,200 hours, not 12:11.
Hey,
Actually, it was 12:10 and 35 seconds, Doc, but, you know, we rounded up.
that's good. And congratulations, Mr. Lane. Patient had complete right hemiparesis. And he is an alcoholic. So the airway's patent, unlabored breathing, sluggish pupils. I'm like, AVPU they did 13. Repeated it. Pretty straightforward. Now, again, there's a blood pressure of 181 over 101 and a 58 heart rate. What were you thinking, Mr. Witherall?
Thinking the same thing.
Yeah.
That's Cushing's.
Yeah.
Cushing's triad.
This is Cushing's triad. They just haven't gotten irregular respiratory rate or apnea. Because they sent this patient by a rotor wing, and I did get some follow-up on this patient. The patient had a bleed.
So the AMA met straight up with an airplane?
They called and met up with an airplane.
No, helicopter.
Helicopter, not an airplane, helicopter.
Okay. Oh, okay.
So, I think the care was good. I think it was appropriate. They realized that this patient was getting Cushing's reflex, and they sent it to a tertiary center. Teaching point again, Cushing's. Now, this patient did not qualify because of the onset of her stroke alert. They were a stroke, just wasn't clear whether it was a hemorrhagic or ischemic. As it turns out, this was a hemorrhagic. And so this was not a code 3 situation because we didn't know. And with all the new literature about large vessel occlusions, yeah, it's still 6 hours, and we had 4.5 technically, but you just didn't know with this guy. So I think overall it's pretty good.
He's also the alcohol history, so it would have been fall.
Could have been, right. So there were some pretty good cases, and I will try to find out about that other woman, because there were lots of things that I had issues with in that case. You know, why they didn't pace her, why didn't they think of atropine? Was her blood pressure really that? Did she have an increased intracranial pressure? Therefore, as Brian said, Cushing's, and I'll try to find out about that and report
Now, if you
back.
have a question on these blood pressure, because you guys are using automatic blood pressure cuffs, do you just say, this doesn't make sense, and then go to a manual one, or say, just palpate a quick top end, let's see what this really is?
What I'll do, first of all, if I don't look, if I've got 2 or 3 that are good, and then all of a sudden I got one that's super low or super high, I usually will re-push it so it'll retake it again. And at that time, I usually end up holding the patient's arm so that they're not leaning jam between the gurney and the wall, which is causing problems, or they're not clenching up, doing something like that. And then if that doesn't get me back to where I normally am, then I'll pull out the manual.
So,
So, question.
answer. You want to go over the test questions?
You mentioned incontinence is not uncommon or is a potential thing in syncopal, but it's not frequent. Is that what I'm understanding? It doesn't have, because I haven't seen incontinence of urine in a syncopal episode.
Normally, yeah, syncope is something, it's a systemic, well, the definition is they lose postural tone, go down, and they recover spontaneously.
The reboot right away.
Right. Yeah, control alt delete, life's good.
Yes.
I'm not sure. That could be that's something that I could do a lit search on. Because I'm trying to search my memory banks whether I have ever seen somebody who was incontinent during a syncopal episode, and nothing springs to mind.
I mean, not every seizure patient becomes incontinent.
Correct. So the incontinence part just bothers me.
Well, I think what we said too is, you know, have they wet themselves a little bit? Or are they wet and soiled? Because that is a true control alt delete when they lose,
Yeah.
you know, sphincter control and all that. It's like, whoa.
Now, is it just a patient who's got weak bladder control anyways? That,
Yeah.
you know, that they didn't put their Depends on this morning and they got a little leakage because of whatever, and it's just a mild oopsies as opposed to I'm seizing and my sphincter is opened up and I've just peed on myself.
I think I need to look at the literature to see incontinence and syncope, and I need to speak to the patient, try to find out some follow-up, what happened to this person. So, please, again, send me cases, send me articles. The next MAC meeting is going to be a Wednesday, April 13th. I don't remember where I have to be on Tuesday, but it wasn't going to work. And any questions, comments before we sign off?
No, that was a good one.
Okay. Thank you, guys. We'll see you.
This is Mary Banner. I have a question.
No answer. No, Mary, too late. What's up?
You have to ask who listened to this so Bill can send them.
What about an MICN class for some of the hospitals?
What do you mean? You want me to put on an MICN class?
Yeah, I'd like to get a MICN class for like some of the hospitals. We can even drive. I mean, we're good with that, but just because I think they'll have, some of the nurses will have more ideas, especially our newer nurses, about the pre-hospital and what they should expect and what they, you know, they understand about pre-hospital.
let me do some exploration on who could put that on, and
Okay.
I will get back to you about that.
Thank you.
You're more than welcome, Mary. And if you could let Bill know who's been listening so he can give you credit, email him.
Okay.
I'd appreciate it. Anything else?
No, that's good for me.
Okay, anybody else?
Sounds good.
Okay, thanks guys.
Sounds good, thank you.